Diabetes mellitus, a comprehensive overview. Introduction. Diabetes mellitus is a group of metabolic disorder characterized by chronic hyperglycemia resulting from defect in insulin secretion, insulin action, or both. This condition has reached epidemic proportion globally, with International Diabetes Federation estimating that 537 million adults were living with diabetes in 2021. This number is projected to rise to 643 million by 2030 and 783 million by 2045. The impact of diabetes extends far beyond blood glucose levels. It is a leading cause of blindness, kidney failure, heart attacks, strokes, lower limb amputation. The economic burden of diabetes is substantial, with direct annual medical costs in United States alone being 237 billion. As future healthcare provider, understanding diabetes is crucial. Let's start with the classification of diabetes. Diabetes is primarily classified into four categories. Type 1 is something which is 5 to 10%. It is an autoimmune destruction of pancreatic beta cells and is diagnosed in children and young adults and requires lifelong insulin therapy. Type 2 diabetes mellitus is most common form. It accounts for 90 to 95% of cases, and it is the insulin resistance and relative insulin deficiency. It is associated mostly with diabetes, sedentary lifestyle. This can be managed with a lifestyle modification, oral medication, and insulin. The third type is gestational diabetic mellitus. It is like 2 to 10% of the pregnancies. They resolve by delivery, but there is increased risk of type 2 diabetes mellitus later in life. So, it can cause a complication in both the mother and child if they are not properly managed. What are the other specific types? There is a monogenic diabetes syndrome. That is maturity onset diabetes of the young. There's diseases of exocrine pancreas like cystic fibrosis. There's drug-induced diabetes, like when the patient is taking glucocorticoids, certain antipsychotics. Understanding these classification is crucial. Why? For the proper diagnosis. And if you diagnose, then you manage, because the pathophysiology is different in all the cases. Each type has a distinct etiologies, presentation, and treatment approaches, which we will explore further. Pathophysiology: to understand the diabetes, we should know about the normal glucose homeostasis. So, in fasting state, the glucose is produced primarily by the liver through glycolysis and gluconeogenesis. After the meal, the glucose level rises. Once it rises, it stimulates the insulin secretion from the pancreatic beta cells. Beta cells are the one which release insulin, okay? Insulin promotes glucose uptake in the muscles, adipose tissue, and suppresses the hepatic glucose production. So, how does it affects the type of diabetes? Like type 1 was autoimmune, right? There was destruction of pancreatic beta cell. Now this is due to cellular and hormonal immune responses. And CD4, CD8 T cell along with the macrophages infiltrate the isolates, causing inflammation, that is insulinitis, leading to beta cell destruction. Autoantibodies against islet cell antigen are present in 85 to 90% of individuals when fasting hyperglycemia is detected. The exact trigger of this autoimmune response is unknown, but is likely involves a combination of genetic susceptibility, and environmental factor. A beta cell mass decreases, insulin production declines. Obviously, the beta cells are producing the insulin. Now the autoimmune and inflammation is causing the beta mass to decline. So once it declines, then insulin production automatically declines. Once insulin declines, then hyperglycemia ensues. All logical. Okay? So when what is the threshold at which the diabetes will appear? It is 80 to 90% of destruction of beta cells are destroyed, and then the clinical symptoms of diabetes will appear. So, what about type 2 diabetes mellitus? Now, the type 2 diabetes mellitus has insulin resistance and relative insulin deficiency. So, how does insulin resistance work? It is due to liver, muscle, and adipose tissue. In liver, it will lead to increased hepatic glucose production, and as we know, once insulin is secreted, the hepatic glucose production is decreased. In muscle and adipose tissue, it will decrease the glucose uptake. After all, insulin is responsible for the uptake. So, molecular mechanism of insulin resistance are complex, and there are defects in insulin signaling cascade. What about the beta cell dysfunction? Now, when the beta cell increases the insulin production to compensate the insulin resistance. Obviously, what we know, diabetes only ensues when 90% of beta cells are not functioning. So, if there is insulin resistance, more islet will work. However, when you make something work more, the function will decrease over time. So, beta cell function decreases, leading to relative insulin deficiency. This deficiency is thought to result from various factors. And what are those? Glucotoxicity, lipotoxicity, amyloid deposition in islets. Okay, the procession from the glucose normal tolerance to the type 2 diabetes mellitus has a path, which is first of all the patient has normal glucose tolerance, and then the patient develops insulin resistance. Now the patient has impaired glucose tolerance with compensatory hyperinsulinemia. Okay. Once the beta cell failure is there, then the patient has diabetes mellitus. Okay. Now, what about the gestational diabetes mellitus? So, in pregnancy, insulin resistance occurs because of the placental hormones. In most patients, beta cell compensate by increasing insulin production. But in some patients, this compensation is inadequate. Because it's inadequate, causes hyperglycemia. The pathophysiology of gestational diabetes mellitus seems to be similar to type 2 diabetes mellitus. It has insulin resistance due to the pregnancy and insulin deficiency both. Now, let's move on to the clinical presentation and diagnosis. So, the clinical presentation of diabetes will vary on the type and severity of the disease. Common symptoms include polyuria, increased urination, polydipsia, increased thirst, polyphagia, increased hunger, unexplained weight loss, fatigue, and blurred vision. Type 1 diabetes mellitus will acutely present with these classical symptoms. Type 2 diabetes mellitus will develop it slowly, with some patients remaining asymptomatic for years. So that's why you hear कि जब डिटेक्शन हुआ तो 600 था. Sometimes patients are diagnosed with diabetes when they develop the ketoacidosis. This is what happens. Diagnosis of diabetes is based on 4 abnormalities. So what are those? We all know fasting plasma glucose level. And what is the level? 126 milligram per deciliter. 2 hours plasma glucose more than 200 milligram per deciliter during an oral glucose tolerance test. What about HbA1c? It will also increase by 6.5%. And we can get a random plasma glucose. So for random blood glucose level that is more than 200 milligram per deciliter in patients who have the symptoms of hypoglycemia. So if there is a clear clinical diagnosis, the crisis or something, then we are confirmed. If we are not confirmed, then we require a second test. Okay. For the second test, we consider the patient as pre-diabetic, high risk of developing the diabetes before diabetes, that is pre-diabetic. So how will we diagnose that? With fasting glucose, that is 100 to 125. So fasting plasma glucose is 100 to 125 milligram DL, that is impaired for 2 hours. Plasma glucose level after patient has ingested 75 milligram of oral glucose. So if that is 140 to 199 milligram per DL, that is another test. What is the third test? That is HbA1c. It has to be more than 5.7 to or 6.4. It can be even higher. HbA1c is something which gives blood glucose level for last an average of last like 3 months. So it is used as a control to know if the patient had taken his drug, has maintained his diet, has done the regular exercise. So it is a way to check also. Okay. So do we recommend normal screening test for diabetes? Actually, we should do. The testing should begin when the patient is 45 years of age. And what if the patient requires this early? How we decide that? Because there are many patients who develop diabetes before 45. So what is the criteria? If the BMI is more than 25, if the patient has a relative who already has a diabetes, or the ethnicity in which there is a lot of diabetes. So what if our pre-diabetic level was there and our confirmatory test is negative? Then what? You will repeat at least every 3. You will do that. And why are we so worried about diagnosing it early? Because early diagnosis is crucial for preventing complication and initiating properly timely treatment. And complications are very severe. So, what are the complications? Acute complications are diabetes ketoacidosis, which is will occur mostly in type 1 diabetes but can occur in type 2. It is classified by like what will you find? Hyperglycemia, diabetes hypoglycemia, ketosis, and metabolic acidosis. Symptoms are nausea, vomiting, abdominal pain, and altered mental status. And what are the treatment? Fluid resuscitation, insulin therapy, and electrolyte management. We cannot cover diabetes ketoacidosis now. It is a very long thing. We'll do it other time. But this is the thing I was telling that many times that patients are in diabetic ketoacidosis and that is the first time we are seeing the patient and then we know the patient has ever diabetes for a long time. So the patient can also be in hyperosmolar hyperglycemic state. So this occurs more in diabetes type 2. There is severe hyperglycemia. There is not significant ketosis. This is different from the last one. And it is generally precipitated by some kind other illness, medication non-compliance. It is similar to diabetes ketoacidosis, but the insulin administration has to be more cautious. Okay. Sometimes it can happen that the patient can also find hypoglycemia. So what are those patients? They are patients who have or on insulin or sulfonylureas. So hypoglycemia, what are the symptoms? Sweating, palpitation, hunger and confusion. Sometimes patient can cause have a seizure or coma. So when you find somebody unconscious, these matlab, if the patient is hypoglycemic or not, this is one of the first things which you need to rule out because it's very common. So the patient will require a rapid glucose administration. So we have seen all these acute complications. We're starting with chronic complications. What is the cause? Microvascular causes are the thing which are causing long-term complication. So most dreaded diabetic retinopathy. Funny enough, although this is preventable, we all know if we take care of our diabetic symptoms, we are taking the medication, we are following the diet, can be prevented, but it is the leading cause of blindness in working age of the adults. There is another diabetic nephropathy. What is that? Kidney failure. This is leading cause of in-stage renal disease. Just imagine what is the burden of this disease which is causing all these other diseases which are leading cause of it. So diabetic nephropathy is another thing. The patients are unable to feel anything and they have pain, numbness and foot ulcer. Why? Because they had a minor trauma and that minor trauma led to an laceration ulcer, small slogging of skin and that has led to big ulcer and it leads to foot amputation. Just imagine. Now, macrovascular. So, in diabetes, we all know that cardiovascular diseases are 2 to 4 times higher and they will cause silent heart attack. The patient will not feel much. Cerebrovascular disease. There is increased risk of stroke. Peripheral arterial disease. It leads to claudication and amputation. And the worst thing is these will impact the quality of life. It will increase the morbidity and mortality associated with the diabetes. It will decrease the productivity of the patient and all of this is preventable if we continue to have a regular screening, early intervention to prevent or delay the onset of this complication. So, after all this, you must be wondering what is the management of this thing. It actually requires a lot of multifaceted approach. It starts with lifestyle modification, which you can modify to improve your blood glucose, improve the condition of the diabetes of the patient. Starts with diet. Like a person should have their individual meal plan. Why? Because every person is different. They have a certain height, they have a certain way of living, they have a certain weight and ratio to it. If they have fat, water, and how their working is differentiating in different days and their energy requirement. That's why they need an individual plan. A 20-year-old who is constantly working on the decks is different than a 20-year athlete. Let's say an sprinter, runner. They have different calorie requirement, although they might be of the same Ethnicity, they might be of same height. Next one, and the patient will should focus on portion control and balanced nutrition, carbohydrate counting for those on insulin therapy, exercise. Exercise decreases the insulin resistance, so we have to aim for 150 minutes of moderate intensity aerobic activity per week and resistance training at least twice a week. And because of increased incidences of cardiovascular risk, we ask the patient for smoking cessation. It will decrease their cardiovascular risk. So, all of this is lifestyle management. Coming next is pharmacological management. So, continuing, in type 1 diabetes, insulin therapy is the mainstay of treatment. That is, patient will require multiple daily injections or continuous subcutaneous insulin infusion. Type of insulin can be varied. In type 2 diabetes, metformin is the first line of medication. There are other medications, and insulin therapy may also be required. So, how does monitoring work? So, we monitor the blood glucose level, can be self monitored or continuous monitoring. HbA1c testing, it reflects the average glycemia over the past 3 months, as I said earlier, and it is generally measured every 3 to 6 months. And we obviously suggest for regular screening for the complications. An annual foot examination, because there's high incidence of foot ulcer which leads to amputation. Annual comprehensive eye examination, as we said, it is the most common, diabetic retinopathy is the most common cause of blindness in working age group. Regular kidney function test, because diabetic nephropathy is the leading cause of chronic kidney disease, as we discussed. So, what are our treatment goals? It should be individualized because, as I said, every person is different. And it should be based on factors such as age, comorbidities, hypoglycemic risk, and what is our goal. Finally, if we are aiming for something, so what are we aiming for? HbA1c less than 7, preprandial capillary plasma glucose of 80 to 130 mg per dl, post peak capillary plasma glucose 180. Remember, diabetes management is more than just the glycemic control. It is crucial to address the cardiovascular risk factor, including blood pressure and lipid management. So, we earlier said there are many diabetes, so we are coming back. So, what about the diabetes in pregnancy? If there is diabetes, there is risk of congenital malformation and macrosomia. So, we require a tight glycemic control before and during the pregnancy. Insulin is preferred, and many oral agents are contraindicated. Why? Because in pregnancy we don't give too much drugs, because first 3 months it can have a teratogenic effect. So what about children and adolescents? They generally have type 1 diabetes, but as we know, it's only after 80 to 90% of destruction of beta cells. So type 2 can occur if there is childhood obesity, and management is very challenging. Why? The patient is having growth, he is having puberty, it will cause hormones, and there are so many psychosocial factors. The patient will think I have to eat the medication every day. None of my friends are having it. Why should I take insulins? So you require education and family involvement. What about diabetes in in elderly? So they have a high risk of hypoglycemia. They generally have other diseases and they have to eat those drugs. So comorbidities and polypharmacy complicates the management because there are many drugs which react with each other, and treatment goal cannot be so stringent because they are at risk of hypoglycemia, which we don't want. So for these special individuals, we should have a tailored approach and we should consider their physiological, psychological circumstances. So what is coming up? Artificial pancreatic system for type 1 diabetes mellitus. There are novel newer drugs like dual GIP, GLP-1 receptor agonists. There is consideration for stem cell therapy for beta cell replacement. There is gene editing going on. Uh, mm, People are thinking of big data and artificial intelligence for the personalized diabetes management. And all these advances will somehow improve the diabetes care. That is what everybody is trying to be. Thank you.